Hello, my dears. How are you? Do you hear me well?
Yes, sir.
Yes, sir.
Fine. Let's get started with our today's lecture devoted to the ocular injuries. Rather interesting topic because in this small topic, uh, we can discuss all the directions, all the branches of the ophthalmology. And of course, it's very, very important to know about the traumas and the principles of their diagnosis and their treatment, because most of such patients with who needs emergency aid, and all the specialists should be ready to help these patients with the emergency aid, with the immediate help, and then make a conclusion, make a decision about the next steps of the medical treatment of line of management of these persons. So, ocular injuries. Last years, the incidence of injuries is increasing in general. Eyes, like any other parts of the body, are also no exempt from these injuries, in spite of the fact that they are well protected by the lids, by the margins of the orbit, by the nose, and orbital fat from behind. Ocular injuries may be grouped as follow: mechanical, electrical, chemical, thermal, and radiational. Additionally, they may be agricultural, industrial, and domestic. And of course, we can divide all the traumas due to the specific clinical features on injuries of children and injuries of adult. Let's start with the superficial injuries. It is usually extraocular foreign bodies. These are quite common in industrial and agricultural workers. A foreign body may be impacted in the conjunctiva or in cornea. And on the conjunctiva, it may be locked in the special position, special place on the inner surface of the eyelid, about 2-3 millimeters from the margin of the upper eyelid. This anatomical structure is called sulcus subtarsalis, and additionally we can find them during the examination in the conjunctival fornices or on the surface of the conjunctiva of the eyeball, like here in this photo in a lower picture, where you can see the foreign body on the surface of the bulbar conjunctiva. In the cornea, it is usually embedded in the epithelium or superficial stroma, rarely into the deep stroma, the superior picture. The usual foreign bodies are particles of iron, emery, and coal. In agricultural workers, these are wings of insects or parts of dust or parts of the vegetables and so on. It may be dust, it may be sand, it may be glass, it may be steel, metal. Foreign bodies produce immediate discomfort, profuse watering, redness in the eye. Pain and photophobia are more marked in corneal foreign bodies than in case of conjunctival foreign bodies. Defective vision occurs when it is lodged in the center of cornea. Examination reveals marked blepharospasm, spasm of the eyelids, and conjunctival congestion. Congestion means dilation of the blood vessels of the conjunctiva. It may be I mean, this congestion may be in several forms. It may be in form of circumcorneal congestion around the limbus, when we can see it in case of corneal inflammation or in corneal foreign bodies like here. Then we can see them. I'm really sorry, I have to switch off the sound. Because we okay, let's continue. So in form of circumcorneal congestion, dilation of the blood vessels around the limbus, and it may be in form of conjunctival congestion, dilation of the blood vessels towards the fornices of the conjunctiva, superior and inferior fornix. It may be mixed congestion. In case of conjunctival foreign bodies, we usually can see the conjunctival congestion. In case of corneal foreign body, circumcorneal congestion. Foreign body can be localized on the conjunctiva and chorda by oblique illumination, or in our real practice, we use special slit lamp examination. What are the most frequent types of complications of superficial foreign bodies? They are acute bacterial conjunctivitis, inflammation of the mucous coat of the eyeball and eyelids. Corneal foreign body may be complicated by ulceration. And finally, even after the successful removal of the foreign body, we can see pigmentation or opacities. They may be left behind by the, especially by the iron or emery particles embedded in the cornea. Treatment. Extraocular foreign bodies should be removed as early as possible with help of a wet cotton swab stick or special needle after topical anesthesia. One drop of anesthetic is usually enough to perform this surgery, this procedure without any problems. After removal of the foreign body, antibiotic eye drops and antibiotic ointment are used for about 3-5 days. And of course, don't forget about the prophylaxis. The best way to prevent such complications and such a situation is to use special protective glasses for industrial and agricultural workers who should be advised to use them during their work. Special guards should be put on the grinding machines, and eye healthcare education should be impaired, especially to the industrial and agricultural workers. The next problem with the superficial injuries is corneal abrasion or corneal erosion. It is the result of small foreign bodies, concretions and trivial traumas in contact lens wearers, for example, or otherwise. These are very painful and diagnosed by fluorescein staining. We use special indicator, fluorescein, normally it's orange in color. We instill 1-2 drops of this indicator into the conjunctival sac and ask the patient to blink for several seconds. Then we wash the conjunctival sac with the saline solution or special drops, antiseptic, antibiotic drops to remove the indicator. But in areas of damaged epithelium, indicator fixed, and as a result of the contact with the changed epithelium, also change its color from orange into the green. With the help of special filters on the slit lamp, we can rather easy determine the area of the damage, the square of the damage, the depth of the damage, and control then the efficacy of our treatment by the same procedure. The main symptoms of this condition are pain, photophobia, and lacrimation. And during the slit lamp examination, we can see erosion of the damage of the superficial layers of cornea. How to treat? We have to use antibiotics in form of drops just to prevent the secondary inflammation. Because
Excuse me, teacher.
Yeah.
The slides are not changing. We are still. We can only see the first slide, introduction.
Really? Okay, let me try to do it again, because on my computer it's a fourth or fifth slide. Okay, let's stop demonstration and then I'll try to do it again. Do you see now other slides? I mean, not only the first one.
No, sir. We can only see the first slide.
Only the first one. And what about now?
Now it changed.
It changed. Okay, let's do it in this format because I think there exists a problem with the wide screen. I'll try to increase the size of the slides as much as possible. I think now it will be okay. So one more time, there were several words about the classification. Here you see the photos. Do you see now?
Yes, sir.
Okay, here you see the photos of two patients with the superficial foreign bodies, corneal foreign body, and conjunctival foreign body. Then complications of conjunctivitis, ulceration, and pigmentation, I mean complications of the foreign bodies, glasses for the protective glasses, and corneal erosion. Here you see the fluorescein staining result of this use of this indicator. And so now we are here. Treatment of corneal erosion, one more time, it's the use of antibiotic drops and ointments for about 3-4 days. But we use them only to prevent a secondary bacterial inflammation. Usually the spontaneous reepithelialization we can see during first 2-3 days, and then we can see the normal cornea. We use antibiotic just to prevent the secondary inflammation, to prevent the secondary infection. We have several drugs in form of ointments, gels, eye gels, which can increase the recovery of cornea, increase the rate and speed of epithelialization, but we use them only in case of rather large erosions. In case of small erosions, no need to use them because in 2-3 days the cornea will be normal without any additional medicines. Very, very large subtopic. It's a contusion injuries, blunt traumas of the eye and eye appendages and the orbit. These are caused by blunt trauma and may vary in severity from a simple corneal erosion to the extensive rupture of the globe with the loss of the contents of the eyeball, with the loss of the visual functions, and sometimes loss of the eye as an organ. What are the traumatic types of damage of different structures of the eye and eye appendages? Let's start with the orbit. So the most frequent problem with the orbit is orbital fracture of the orbital walls. You know that there are 4 walls in the orbit: superior, inferior, lateral, and nasal. There may occur fractures of all of them, the thinnest wall of the orbit is the nasal wall, which at the same moment is the wall of the nasal cavity. So it may be emphysema, crepitation during the palpation because of the spreading of the air from the nasal cavity into the orbit during this trauma. And the commonest type of trauma is being the blowout fracture of the orbital floor, the inferior wall of the orbit, which is at the same moment is the superior wall of the one of the paranasal sinuses, you know. And orbital hemorrhage behind the eyeball may produce sudden proptosis, protrusion of the eyeball outward. Sometimes maybe, on the other hand, maybe anophthalmos, when we can see that the eye looks like a very small eye due to the fractures of the orbital walls and position of the eyeball, low position, low down into the orbital cavity. Like here, you see the blunt trauma by the ball, you tennis ball, or maybe different other types of agents, because the sport blunt trauma it's a very common type which cause the contusion of the eyeball. And here you see the patient with the, it looks like he has the two eyes at different levels, horizontal levels. This is the normal, this is the eye, dislocated eyeball due to the fractures of the orbital wall. And like in this picture, you see the position of the changed position of the eyeball here in the orbit. Of course, in such patients, maybe additional symptoms like diplopia, double vision due to the abnormal position of the injured eyeball. Uh, Very often, such a severe trauma associated with the damage of the inner structures of the eyeball, which we'll discuss a bit later. What about the lids during the contusional traumas? Ecchymosis is a special term. You remember that we use a lot of Greek words. So one more Greek words, one more term, ecchymosis. This is it's a frequent type of eyelid disorders. It is subconjunctival hemorrhage with the spreading of the blood into the structure of the eyelids, and because of loss of subcutaneous tissue, blood collects easily into the lids and produce the syndrome of the black eye. There may be other disorders like laceration and avulsion of the eye of the lids. Maybe damage of the muscles which supply which take part in the movements of the eyelids, and sometimes we can see the so-called traumatic ptosis. Ptosis means impossibility of our patient to open the palpebral fissure due to the pulling down the upper eyelid, and sometimes we need a surgical treatment for these patients. Traumatic ptosis may follow damage to the elevator palpebral superior muscle. In case of such a picture as in this photo of the patient with when his eyes looks like a black glasses, we have to differentiate between the isolated eye trauma and facial trauma and the fractures of the bones of the base of the skull, because black eyes syndrome sometimes it's a sign of this such a severe neurosurgical pathology, and the general conditions of the patient can help us to differentiate. And if it's an isolated pathology of the eyes and paraorbital structures, we have to treat them. I mean, we ophthalmologists, but if it's a neurosurgical treatment, only neurosurgeons in the special neurological, neurosurgical departments should treat them with our help, of course. But the basic problem is the fractures of the base of the skull, and severe. It's a real risk of for the patient's life in this case. Lacrimal apparatus. During the examination of the lacrimal apparatus, in case of blunt trauma, we can find dislocation of the lacrimal gland, rather severe damage. It may be loss of the function of the lacrimal gland with the dry eye syndrome development, or on the other hand, it may be excessive production of tears due to irritation, due to trauma, with the tearing, with the lacrimation for a long period of time. And sometimes we can see damage of the lacrimal canaliculi, lacrimal punctures in the middle angle of the palpebral fissure. In this case, if we can see the rupture of the lacrimal canaliculi, it may be a problem with the tears outflow. And additionally, we can see tearing, excessive lacrimation in these patients. In most of the problem with the lacrimal gland, traumatic, inflammatory, and others, lacrimal gland and lacrimal passages, the basic symptom is lacrimation. Conjunctiva. In case of conjunctiva, we can see the so-called subconjunctival hemorrhages. Here you see the patient with a huge subconjunctival hemorrhage. We can see a lot of blood between the conjunctiva and underlying sclera. It appears a bright spot in case of small trauma, but here you see more severe trauma. In this case, it's necessary to exclude more severe damage of the inner structures, for example, scleral rupture, because through this blood you can't see the surface of sclera, and it's difficult to understand are there only isolated superficial trauma or rupture of the globe with the scleral tear and scleral rupture. Because this situation, if it's an isolated subconjunctival hemorrhage, needs no special treatment, no surgery. In 5, 7, no, maximum 10 days, it will be a normal condition due to the spontaneous resorption of this blood. But in case of scleral rupture, the only way to help the patient and to save the eye is to perform the immediate emergency surgery. So it's very, very important moment in case of such a huge hemorrhages to differentiate between the superficial and deep trauma. Cornea. In case of trauma, we sometimes see the corneal erosion, which we have already discussed. And let's continue with the inner structures of the eyeball. Sclera. I started with the explanation of scleral tears. The complication of the open wound of sclera is a prolapse of inner structures, uveal tissues, choroid, vitreous loss, and of course, different hemorrhagic complications, intraocular hemorrhages, a dislocation of the lens, retinal detachment, damage of the optic nerve, and so on and so forth. It's a very, very severe trauma with a doubtful prognosis for the vision and even for the eyes, for the organ, because sometimes even after the successful surgery, we can see in several months or years, we can see atrophy of the globe with the shrinking of the eyeball, with the loss of visual functions, and without any signs of healing. Anterior chamber. Anterior chamber, it's a place between the inner surface of the cornea and anterior surface of the iris and crystalline lens. Normal anterior chamber looks normally empty, but we know that it fills with the aqueous humor. In case of trauma, we can see blood in the anterior chamber. This condition is called hyphema, another Greek word. Sometimes we can see collapse of the anterior chamber, usually the result of the corneal perforation. Normally, depth of the cornea, anterior-posterior depth, is about 3.5 millimeters. In case of severe trauma, it may be 1 millimeter or even absence of the anterior chamber with the contact of cornea and underlying iris. In case of loss of the anterior chamber, collapse of the anterior chamber, it's necessary to recover it, usually surgically. In case of presence of blood in the anterior chamber, our strategy, our tactics depend on the amount of blood. In case of small amount of blood, like here in this photo, it's about 1-2 millimeters on the bottom of the anterior chamber, it's enough to use only medical treatment to increase the blood in the anterior chamber, because you know that the exchange processes inside the eyeball, they have a rather high speed and it will be a spontaneous resorption. But if we can see that blood fills all the anterior chamber, it's sometimes necessary to wash the anterior chamber through the so-called paracentesis. It's the small incisions less than 1 millimeter. In this case, it will be very good to wash the anterior chamber to prepare the eye for the better recovery. Uveal tract. Anterior part of the uveal tract consists of the iris, we can see iris rupture of the pupillary margin, the so-called iridodialysis. And here you see patient with two such iridodialysis due to trauma. You see the pupil in the center, and here you see two detached parts of the retina, two ruptures. We can see sometimes change of the size and form of the pupil. In case of size, it may be traumatic miosis when the pupil is very small, less than 2 millimeters, 1 millimeter. On the other hand, sometimes we can see dilated pupil, the so-called mydriasis. And sometimes you can see change of the form of the pupil. Normally, it's a spherical form, but sometimes it may be oval or irregular form of the eyeball due to the ruptures of the sphincter of the pupil, the muscle which is located here around the margin of the pupil, and so on. Crystalline lens, also very important structure, which may be involved in the process of trauma. And the most frequent type of lens changes is cataract, opacity of the crystalline lens, of different severity, of different degree. Sometimes we can see small opacity somewhere on the periphery or under the capsule without any loss of visual functions, or very small problem with the vision. In this case, sometimes no need to use any surgery. But in most of cases, the intensity of opacities are rather high, and patients' complaints on the decreased vision is the indication for the cataract surgery we have to remove the opaque crystalline lens and implant artificial crystalline lens. The prognosis for this surgery is very good. Cataract surgery is the most frequent type of ophthalmic surgery in all the world, and the line of management of such patients, the strategy has no problems on all the steps. So we have a very good machines. We have a very good technologies for the cataract surgery. So it's an uncomplicated, sutureless, very effective, very quick type of surgery for the recovery of visual functions. If it's an isolated opacity of the lens without any damage of the inner structures, the result will be very good. The vision will be normal after the surgery. Sometimes we can see more severe problem. I mean the dislocation of the lens. And here you see such a patient, symptom of sunrise. Here you see only the anterior pole of the lens in the area of the pupil, and all the lens is dislocated down inside the vitreous body into the vitreous cavity. In this case, we have to use additionally to the cataract surgery, vitreoretinal surgery. Usually there are no ways to put this lens into its normal position and to fix it. We have to remove this lens, dislocated lens, even if it's a transparent lens. We have to remove it and then implant special models of the artificial lenses, also with a very good result. Vitreous body. Vitreous body, as you know, it's a gel behind the crystal lens, which fills the posterior part of the eyeball. And problem with the vitreous, maybe loss of vitreous in case of ruptures of sclera, or hemorrhages, the so-called hemophthalmos. It may be total or partial, or it may be a total or partial detachment of the vitreous from the underlying retina. Our line of management of these persons depend on the severity of the pathology. In case of the blood in the vitreous body, we can wait if it's not so intensive blood, and sometimes we can see spontaneous resorption. Sometimes we need the surgery. We have to remove this blood with the help of the so-called vitreoretinal surgery. Through the very small incisions, less than 0.5 millimeter, we put the special, very, very thin instrument into the vitreous and remove the blood, aspirate the blood. We use the ultrasound energy in this case, like in case of cataract surgery, and also very effective surgery. In other cases, in case of vitreous detachment or opacities, our treatment depends on the severity of these clinical features. If they're not so severe and the visual functions are rather high, it's no need to use any surgery. We can just wait. Choroid, the posterior part of the uveal tract. And retina, underlying retina. Traumatic changes of two of these structures include choroidal and retinal hemorrhages, ruptures of the choroid, contusional edema of the retina, and retinal detachment, the most severe type of the pathology. In most of cases, traumatic changes of the retina and choroid are associated with the severe loss of visual functions. And prognosis depends on the severity of trauma, spreading of the trauma onto the surrounding tissues, area of damage, localization of damage, because changes of the central retina in the yellow spot or peripheral retina, it's different. And of course, the prognosis is doubtful in case of severe prognosis for the visual functions is doubtful in case of the severe traumas of the retina. Our treatment depends on the stage, severity of this trauma. Sometimes we need only medical treatment, sometimes surgery, sometimes combination of these two strategies. Optic nerve. Optic nerve injuries are commonly associated with the fractures of the base of the skull. This may be in the form of traumatic papillitis, traumatic inflammation of the optic nerve head, laceration of the optic nerve sheath hemorrhage, and avulsion of the optic nerve from the back of the eye. Avulsion with, of course, total and irreversible blindness. We have no mechanism, no technologies how to recover the optic nerve in case of its total damage, in case of its rupture, in case of its avulsion. Another changes in case of contusional injuries are associated with the change of the intraocular pressure. It may be two types. It may be increased intraocular pressure with the development of the traumatic glaucoma, or on the other hand, it may be hypothony due to the damage of the ciliary body. Ciliary body, I remind you, it's a structure which produces the aqueous humor. If it will be severe damage of the structure, there will be no production or decreased production of the aqueous humor, and of course the anterior, the intraocular pressure will decrease. Hypothony has a risk of shrinking of the eyeball with the development of the eyeball atrophy, and of course we have to try to increase the intraocular pressure in these cases, sometimes even with the surgery. So you see very large spectrum of the changes. In most of cases of severe traumas, it's usually association of different types of trauma. It may be associated trauma of eye appendages like eyelids or conjunctiva with the eyeball structures. It's very seldom situation when we can see isolated damage of inner structures of only one inner structure of the eyeball. In most of cases we can see associated trauma of the iris with the crystal lens with the vitreous body with the retinal changes, and so on and so forth. And of course each new additional structure involved in the trauma increase the doubtful prognosis for the recovering. The next group of disorders are perforative injuries. They may cause severe damage to the eye and so should be treated as serious emergencies. They may be caused by sharp and pointed instruments, foreign bodies with the high energy, which enough to make a hole in the outer coat of the eyeball. Travel in an extremely high speed usually. The main effects of perforative injuries are mechanical, which include wounds of the conjunctiva, wounds of the cornea, complicated and uncomplicated, which associated with prolapse of inner structures, usually iris, sometimes lens, meta, and even vitreous. Then changes damage of the sclera and of the crystalline lens. Then such an open wound, is a gate for the introduction of infection. Damage of the inner structures may cause the post-traumatic iridocyclitis, inflammation of the anterior part of the uveal tract. And finally, we can see one more type of inflammation, which we'll discuss in the second part of our today's talk, sympathetic ophthalmitis. diagnosis. All the signs of perforative injury we can divide into reliable and doubtful. Presence of even one reliable sign, it's a 100% of presence of perforative wound. In case of doubtful sign, doubtful means that we have a symptoms which looks like a perforation, but it may be symptoms of other disorders, even of case of contusion, which we have discussed earlier. So reliable signs of perforative wounds. Visible wound. If you can see the wound, it's clear that it's a perforation. Prolapse of inner structures. You can't see the wound because it's in area of the wound, you see the, for example, iris, but presence of the inner structures out of the eyeball, it's clear that there exists a perforation. Aperture in the iris, you can't find the primary wound in the outer coat, but you see the wound in the inner structures. Of course, we can't imagine that it will be a inner wound without a perforation of the outer coat. And presence of intraocular foreign bodies. Sometimes patients come to us after it's several months after the trauma, and we can't find the primary wound because due to its spontaneous closing. But if you see the foreign body inside the eyeball, of course you understand that it was a perforation. And doubtful signs. Doubtful signs of perforative injuries are hypothony. It may be in case of contusional injuries. Shallowing or flattering of the anterior chamber also may be in case of contusion. Changes of the pupil shape also may be in case of contusion. So in this case, it's necessary to understand and to differentiate between the contusional injuries and perforative injuries. Okay, about the immediate help, about the treatment, the line of management of these patients and clinical symptoms with additional portions of very interesting pictures will continue in 10 minutes after the break. So let's continue at 5 minutes to 5. Okay. Okay, my friends, are you here? Do you hear me?
Yes, sir.
Let's continue our today's talk. And we'll continue with the immediate management of global perforation. This includes antibiotics, systemic antibiotics, antibacterial drops for the local topical treatment. Then tetanus antitoxin should be administered if necessary, and binocular bandage. If it's a painful condition, we can use analgesics to decrease the intensity of pain. Ultimate therapy is surgical repair under local or general anesthesia. Wounds, if they are present, should be always sutured. Very important thing for us, very important situation is to determine the presence of the intraocular foreign body. Common foreign bodies are chips of iron and steel, particles of glass, stone, plastic, or wood. All foreign bodies may be classified as magnetic and non-magnetic. It's very important for our tactics. In case of magnetic foreign body, we can remove them with the help of special medical magnets. If it's a non-magnetic like glass or wood or plastic, only with the special instruments, special forceps, knives, we can perform this. Diagnosis includes history, which help us to determine type of intraocular foreign body. If we know what's happened, we can suggest what type of foreign body, magnetic or non-magnetic, wood or metal, and so on. Ocular examination, where we can find signs of perforative injury, which we discussed in the previous hour, reliable and doubtful signs. X-ray examination, the most effective method of the examination of the intraocular foreign bodies with the help of special Comberg-Baltin indicator, which I'll show you on the next slide. We can determine the position of the foreign body and to find the best area for the cut during the surgery for removing of the foreign body. Special aluminium, and of course we can use ultrasound, we can use computer tomography, but sometimes it's rather difficult. In case of ultrasound, if it's very small foreign body, even metal foreign body, it's difficult to find it. Method of radiographic localization by Comberg-Baltin. We use special aluminum indicator. It looks like a contact lens, which we put on the surface of the injured eye. This indicator has 4 dots on its surface, which we can see during the on the X-ray picture. If you see it, this is the X-ray with the help of this indicator, and you see 4 white dots. If we perform the anteroposterior and lateral photos of pictures of the X-ray pictures of the patient, we can determine the meridian of the localization and depth of the localization of the intraocular foreign body. And with the help of special schemes, we can determine the position of the foreign body inside the eyeball. It will help us in our next step, I mean surgery. Sometimes, in case of bone-free X-ray are used to determine the position of non-metal foreign bodies. Ultrasound and computer tomography localization is useful in diagnosis of intraocular foreign bodies. So we try to use all the methods for the best localization of this, of the position of the foreign body inside the eyeball. Because we have to use the safe and effective surgery. And the only way to perform it is to know exactly the position of the intraocular foreign body. Treatment of the intraocular foreign bodies. Of course, all of them should always be removed. Removal of magnetic foreign bodies, as I said before, is easier than the removal of non-magnetic. Usually a handheld magnet is used in case of magnetic foreign bodies. The way of removing depends on its localization. There exist three main ways. Anterior, when intraocular foreign body is situated in the anterior segment of the eye, usually we can see it with our eyes with a special slit lamp examination. Then direct, when intraocular foreign body is located in the superficial layers, one tip of the foreign body, for example, inside the eyeball, and the other tip is out of the eyeball. We can remove it through this wound. And transscleral, the commonest way for the posterior foreign bodies, intraocular foreign bodies. We count the localization with the help of indicators, then make a cut in sclera and remove it. Or we can use vitreoretinal surgery when we can remove vitreous body, we can remove the intraocular foreign body, we can use any additional manipulations for the damaged inner structures. It depends on situation. The main complications of perforative injuries with the retention of intraocular foreign bodies are traumatic cataract. Here in this photo, you see the opaque crystal lens. You see associated damage of the iris with the iridodialysis. You can see the scar of the cornea, and so on and so forth. Additionally to the traumatic cataract, maybe introduction of the infection with the development of the different types of inflammation, post-traumatic iridocyclitis, then sympathetic ophthalmitis, and reaction on the foreign body. If foreign body is present in the eye for a long period of time, it will be chemical processes, contact of the foreign body with aggressive in substances, aqueous humor, vitreous body, and chemical reactions which may cause very severe damage of inner structures. There exist several types of reactions on foreign body, and they depend on the type of the foreign body. The most frequent types are iron foreign body and copper foreign body. The problems with the long presence of the iron foreign body is called siderosis. Siderosis bulbi, or siderosis of the eyeball. It refers to the degenerative changes produced by an iron foreign body. This usually occurs after half a year of the injury. The iron particle undergoes electrolytic dissociation by the current of rest, and its ions are disseminated throughout the eye. The anterior epithelium and capsule of the lens are involved first of all. You can see the rust deposits, they are arranged radially in a ring. Here you see them on the surface under the epithelium of the anterior capsule. The lens became cataractous. Cataract with associated opacities under the anterior capsule is a sign of the presence of the iron foreign body, and you can suggest that foreign body is really here. Iris is first stained, and the iris becomes dirty. So you can see heterochromia. If you look at the patient, you'll see that the iris in this damaged eye has different color comparing with the iris of the normal eye. Additionally, we can see the damage of the retina. Retina develops pigmentary degeneration. Then secondary glaucoma and secondary iridocyclitis may be the result of degenerative changes. Presence of the copper foreign body causes the so-called halcosis. It refers to the specific changes due to the presence of the copper foreign body in the eye. Clinical features: sunflower cataract, another clinical picture, produced by deposition of copper under the posterior capsule of the lens, not anterior but posterior capsule. It is brilliant golden green in color. A retinal examination may show deposition of golden plaques or at the posterior pole, which reflected the light with a metallic sheen. Sometimes we can find the presence of the rest of the foreign body in the eyeball. Sometimes we can see only these post-inflammatory toxic changes, but we can't find the foreign body due to its resorption during these electrolytic biochemical processes. But treatment is surgical. If the existing foreign body still exists, we have to remove it. If it's a cataract, we remove the cataract. But reaction may be not as a result of the metallosis. It may be in form of different type of inflammation. Unfortunately, in a lot of cases, we can see severe purulent inflammation. Purulent uveitis is very dangerous complication of perforative injuries of the eye. It may start as purulent anterior uveitis, the so-called iridoceclitis, or purulent posterior uveitis, the so-called choroiditis, which soon progress to involve the retina, vitreous, and result in purulent endophthalmitis or even panophthalmitis, inflammation of all the coats, all the tunics of the eyeball. In some cases, endophthalmitis may be caused by corneal ulcer or perforative infections following intraocular operations. It may occur rarely through bloodstream from some infected focus in the body, such as caries teeth, generalized septicemia, and so on. Causative organisms are Staphylococcus, Pseudomonas, Escherichia coli, Pneumococcus, and Streptococcus. No, it's a common microorganisms. Symptoms of endophthalmitis are ocular pain, redness of the eye, excessive lacrimation, and marked loss of vision. Additionally, we can see lid edema, conjunctival edema, caused hemosis, named hemosis, called hemosis, marked circumcorneal or circumciliary congestion. We discussed before, what does it mean? Dilation of the blood vessels. Corneal edema, like in this photo, you see all these signs, corneal edema, exudates in the area of the pupil. Normal area of the pupil looks black. Here you see it's whitish due to presence of exudate and pus in the area of the pupil. Pupil shows yellow reflex due to purulent exudation in vitreous body. Treatment include broad spectrum antibiotics, topically, in form of subconjunctival, parabulba, or even intravitreous injections, and local topical treatment in form of drops, and systemic antibiotics, mydriatics, to prevent and to decrease the signs of inflammation. We have to dilate the pupil. Corticosteroids, and of course, non-steroidal anti-inflammatory drugs are also rather effective. Surgical treatment, enucleation. It means removing of the eyeball. Enucleation may be performed in case the patient doesn't respond to the urgent intensive therapy, including vitrectomy. So if you can see no efficacy of your treatment and there exists a real risk of spreading of the infection in the brain, in the surrounded structures, organs, the only way to remove the eyeball, unfortunately. Panophthalmitis. It is an intense purulent inflammation of the whole eyeball, including the Tenon's capsule. Etiology is the same as described for endophthalmitis. Symptoms include also the same symptoms. Most of them are the same, like in case of endophthalmitis, but they're more severe. Severe ocular pain and headache, complete loss of vision, profuse watering, purulent discharge, marked redness and swelling of the eye, associated constitutional symptoms like fever may be present. Here you see the eye, very difficult to treat such patients. So signs are edema and hyperemia of the lids, slight proptosis of the eyeball, protrusion of the eyeball outward, out of the orbit. Ocular movements are limited and painful due to involvement in the process, the retrobulbar fat and orbital fat and extraocular muscles. Hemosis of the conjunctiva. Hemosis means severe edema of the conjunctiva. Mixed congestion. No, all the eye is reddish. Cornea, as you see here in the photo, is cloudy and edematous, and anterior chamber is full of pus. And of course, we can't see inner structures, underlying structures, because of the presence of the pus in the anterior chamber. Vision is completely lost, usually without any chances for the recurrent, and perception of light is absent. Global perforation may occur in this case due to the ulceration and thinning of the outer coat due to the severe inflammation. Treatment. Intensive antibacterial therapy, broad spectrum antibiotics in all the forms, anti-inflammatory drugs, and analgesics to relieve pain. Evisceration. Operation of evisceration should be performed to avoid the risk of intracranial dissemination of infection. Evisceration means we remove all the contents of the eyeball, but leave in the orbit the outer coat of the eyeball. Also very difficult surgery. One more severe complication of the previous trauma, perforative trauma, is the so-called sympathetic ophthalmitis. It is bilateral, granulomatous, panuveitis. Panuveitis means inflammation of all the parts of the uveal tract, anterior part, iris and ciliary body, and posterior part, choroid. So this is panuveitis, which follows a penetrating ocular trauma. It may develop about 4 to 12 weeks after either an injury or rarely intraocular surgery of the eye. Etiology is still known exactly, is still not known exactly, and we suggest the autoimmune nature of this disorder. Most accepted is the immune allergic theory. Clinical picture. The injured eye is called exciting, and the fellow eye, which also develops uveitis, is called sympathizing or sound eye. The most dangerous and difficult for treatment feature of this sympathetic ophthalmitis is the inflammation of both eyes, not on the injured eye, but unfortunately the normal eye. Autoantibodies, which present in case of open trauma, they damage both eyes. Normal, healthy eyes also. And it may cause the total blindness without treatment. So sympathizing or normal eye is usually involved after 4 to 8 weeks of injury in the other eye. The early symptoms of sympathetic ophthalmitis are sensitivity to light, the so-called photophobia, lacrimation, transient indistinctness of near object, weakness of accommodation. So, of course, now it's a very rare condition because in all the trauma, just after the trauma, after the surgery, we use corticosteroids, which prevent development of the sympathetic ophthalmitis. But in case of severe traumas, very rarely, but we can see such patients. And all the persons after the successful surgery, which when we let them go home, we should discuss with them that if they'll see the even mild photophobia or lacrimation in the normal healthy eyes, they should immediately visit the doctor, the ophthalmological hospital, because it may be a sign of the early signs of sympathetic ophthalmitis. Signs, they're typical for iridocyclitis. You see here the presence of the deposits of pigment of inflammatory cells on the inner surface of the cornea, on the endothelium, the so-called keratic precipitates. We can see sometimes blood in the anterior chamber. We can see edema of the iris, all the signs of the iridocyclitis. Additionally, circumcorneal congestion, changes of iris color, formation of the posterior synechia, adhesion between the posterior surface of the iris and anterior capsule of the crystalline lens. Treatment. Medical treatment includes steroid therapy by all routes, local, systemic, and so on. We can use it local in form of drops, in form of injections, periorbital injections, frequent instillation of eye drops, and so on. Mydriatics, topical mydriatics, drugs which dilate the pupil to prevent formation of the synechias. Antibiotics. In severe cases, immunosuppressive therapy. In severe cases, immunosuppressive therapy. Treatment should be continued for a long time. Prophylaxis is an early excision of the injured eye. If you see the light, the first early signs of sympathetic ophthalmitis, if in this period you manage to remove the eyeball, injured eyeball, this is the best way for prophylaxis of the autoimmune damage of the normal eye. Prognosis in case of sympathetic ophthalmitis depends on the stage. If you start with the steroids or if you remove the eyeball, the prognosis is rather injured eye, the prognosis is rather good. In advanced cases, prognosis is very poor, even after the best treatment. Unfortunately for the both eyes, and here you see the patient with bilateral damage of the eye, you see bilateral loss of transparency of the anterior segment of the eye and bilateral blindness. Chemical burns, chemical or thermal burns of the eye. Chemical burns are the most urgent and are caused usually by alkali or acid. There exists a difference in the clinical picture, in the symptoms of these two types of damage. And alkali burns usually more severe than the acid burns because of their rapid penetration, often less than 1 minute, through the cornea and anterior chamber, combining with cell membrane lipids. Damage from alkali burns is related more to the degree of alkalinity, pH, than to the actual caution. Permanent injury is determined by the nature and concentration of the chemical, as well as by the time lapsed before irrigation. Acid burns cause their maximum damage within the first few minutes, from minutes to hours, and are less progressive and less penetrating. Acid precipitates tissue proteins that rapidly set up a barrier against deep penetration by chemicals. So there exists a sort of coagulation of the tissues, and these coagulated tissues like a barrier between like a border between the normal and damaged tissues. In case of alkali burns, there exists a deep penetration due to presence of another type of necrosis, coagulation necrosis, without formation of a sharp border between the damaged and normal tissues. Grading of chemical burns. There exist 4 stages of chemical burns. I show you the photo of them and explain each stage. So grade 1, we can see hyperemia of the conjunctiva and erosion and edema of corneal epithelium. This is the first grade of chemical or thermal burns, the same classification for both types. Then grade 2, we can see ischemia of the conjunctiva. Conjunctiva is in first stage is hyperemic. In case of second stage, it becomes grayish and hemotic. Areas of clouding may appear in cornea as the result of its infiltration, and may be loss of corneal sensitivity in this stage due to the damage of the tips of the nerve endings in the cornea. The third stage, grade 3, total corneal epithelial loss and stromal clouding. And finally, deep conjunctival necrosis, 4th grade, deep conjunctival necrosis and corneal necrosis. Cornea is china in color, partially or totally. What are the complications of chemical burns? Superficial neovascularization. Neovascularization means growth of the new blood vessels, abnormal blood vessels. Normally, you know, our cornea is transparent and free of blood vessels. It's a vascular structure. Here in this photo, left one, you see the growth of the blood vessels in the cornea. Cornea is additionally opaque. It's the so-called glaucoma, partial, in this case, total loss of its transparency with the growth of the blood vessels, neovascularization. Then, development of symblepharon. Symblepharon, it's an adhesion between the conjunctiva of the eyelids and conjunctiva of the eyeball. Due to their damage, it will be a connection of these two parts of the conjunctiva, the so-called symblepharon. A recurrent corneal ulceration, corneal ulcer, whitish with the development of the secondary purulent inflammation. And also sometimes we can see complicated cataract, opacity of the lens, and even secondary glaucoma, increased intraocular pressure. Immediate treatment of chemical burns, as you know, thorough wash with the available clean water. The greater the time between injury and decontamination, the worse the prognosis. As soon you start your washing of the conjunctival sac, as better the prognosis. Mechanical removal of contaminant from the conjunctival sac and corneal surface is needed. Sometimes we can see chemicals not only in form of the liquid, but in form of powder, in form of parts of the chemical substance, solid parts of the chemical substances. All of them should be removed as soon as possible. Stop the contamination and then continue with the treatment, which include irrigation of furacilin solution or normal saline solution, antibacterial drops and ointments to prevent secondary inflammation, mydriatics to prevent or to treat the anterior uveitis, analgesics to relieve the pain, antihistamine drugs to decrease the allergic component of inflammation, vitamin C, like the antioxidant therapy, and treatment of complications. On the previous photo, there were a lot of complications All of them should be treated surgically. In case of total loss of corneal transparency, transplantation of cornea, in case of formation of adhesion between the conjunctiva of different structures, the so-called symblepharon, we should cut this symblepharon. In case of cataract surgery, in case of glaucoma, anti-glaucomatous surgery, and so on and so forth. Burns may be not only chemical, it may be caused by the different types of radiation. Radiation burns may be infrared, caused by ionizing radiation, may be caused by ultraviolet radiation, the most frequent type, but maybe the easiest for treatment type is ultraviolet radiation damage. Infrared burns are usually of little consequence and produce only temporary lymphedema and erythema, but little or no damage to the globe and inner structures. Chronic exposure to infrared light is seen in glass blowers and metal furnace stokers improperly protected by industrial goggles. These workers develop cataract after many years of exposure. And very rarely may be retinal edema, vitreous, and retinal hemorrhage. Ionizing radiation. The cornea, lens, uveal tract, retina, and optic nerve may suffer from injury, from this type of injury, but also may be protected from it by use of special screens and special glasses which can absorb X-ray or gamma or neutron radiation. Signs and symptoms are conjunctival hyperemia, circumcorneal congestion, and radiation keratitis, inflammation of the cornea. The minimum cataractogenous dose from X-ray is approximately 5 to 800 rad. The younger the lens, the greater the vulnerability to X-ray. A latency period of 6 months to 12 years exists depending on dosage. The uveal tract may undergo vascular dilation with subsequent edema. Intraretinal hemorrhages or even papillary edema, edema of the optic nerve, and central retinal vein thrombosis may rarely be seen after radiation injuries. And treatment of both infrared and ionizing damage depends on the type of damage structure, and maybe surgical or medical. Ultraviolet radiation is the most common cause of light-induced ocular injury. Sources are welding arcs, sun lamps, and carbon arcs. Photoophthalmia refers to occurrence of multiple epithelial erosions due to the effect of ultraviolet rays. Unfortunately, for those who didn't use protective glasses or screens, it's a very common condition. After an interval of 4 or 5 hours, latent period of exposure to ultraviolet rays, there occurs discrimination of corneal epithelium, leading to formation of multiple epithelial erosions with clinical picture of severe pain, photophobia, lacrimation, blepharospasm, swelling of the conjunctiva, and conjunctival hyperemia. And usually at night, they come to the ophthalmological hospital with these symptoms. Treatment: analgesics, antibiotics, and cold compressors to relieve their subjective symptoms. Because here, in this case, the severity of subjective symptoms is more than the real objective clinical picture or dangerousness of this condition. So very important to explain the patient that it is not a severe damage and in several hours, maximum 1 day, the symptoms will decrease, or if it will be even a total recovery if it's a small erosion. Antibiotics were used just for prophylaxis of secondary infection, and of course, it's necessary. It's better. The better way to prevent it's use of special glasses which absorb this type of rays. That's all in this lecture. That's all for today. Thank you for your attention. If you have any questions, you can ask me now or individually with the chat or during our practical classes. Any questions?
No, sir.
No, sir.
Okay, thank you for your attention. Have a good days and
You too.
see you during our practical classes. Bye.
До свидания.
До свидания, sir.